name is Nasiru Jinjiri Ismail. I'm the former head of neurosurgery in the Regional Neurosurgery Center in Usman Danfodio University, Sokoto. And I'm the current president of the Nigerian Academy of Neurological Surgeons, that's NANS. I'm excited to collaborate with the West African Stroke Initiative to introduce and expand endovascular neurosurgical intervention and stroke care in Nigeria. We have several stakeholders from various parts of the world joining us today, including neurosurgeons, radiologists, neurologists, nurses, technologists, and hospital administrators. We usually put together this grand round on bi-monthly basis. And the title of today's grand round is Vein of Galen Malformation. Before I introduce our moderator and presenter for today, I would like to do a few housekeeping. Mute your microscope unless called upon by the moderator or presenter. And when sharing screen or video, be mindful of what is in your background. We expect there may be a few technical hiccups. Kindly wait them out. Ask question will have opportunity to answer questions after the presentation. If you have question during the session, please type it in the chat box. The moderator will read your question to the presenter during the question and answer session. Additionally, if you would like to ask a question directly, use the raise hand feature or in the Zoom, and you'll be invited to ask questions. So our moderator today is Dr. Chizoba Izepe. Dr. Izepe is an attending physician, international and interventional and vascular neurology, Neurosciences Institute, SSM Health, DePaul Hospital, St. Louis, Missouri, in the United States of America. I hope I pronounced it clearly. Sorry.
That's okay. It's about Ezekiel from SSM Health, DePaul Hospital, St. Louis, Missouri. You're right.
Dr. Tudepe, if I made some mistake. Dr. Tudepe, our presenter today is Professor Jonathan Fifi. Dr. Fifi is a professor of neurology, neurosurgery, radiology at Icahn School of Medicine in Mount Sinai. She is also Associate Director of Cerebrovascular Center, Director of Cerebrovascular Services at Mount Sinai Hospital, and Director of Pediatrics Cerebrovascular Program. She is the immediate past president of the Society of Neurointerventional Surgery, past board member of the Society of Vascular and Interventional Neurology, and past committee chair of the U.S. accrediting body for neuroendovascular surgery fellowships. She has led a number of clinical research trials into adult and pediatric cerebrovascular disease and stroke systems care. Dr. Fifi has authored over 200 publications and is an associate editor of the Stroke, Vascular and Interventional Neurology Journal. Dr. Fifi specializes in endovascular treatment and cerebrovascular disorders, including vein of Galen malformation, arteriovenous malformation, fistulas of the brain and spine, stroke, brain aneurysm, intracranial carotid stenosis, as well as craniofacial vascular lesions in children and adults. Professor Fifi, really welcome. And
thank you.
Yes, you're welcome to the presentation. We are going to open it up for questions and answers. Over to you, Dr. Izepe.
Okay.
Dr. Izepe.
Professor Fifi, please proceed with your presentation, after which, I would come over to address the questions that people may have If
Okay.
you have any questions during the presentation, please try not to interrupt. Just type your questions in on the chat and we would read it out later on. Thank you. Please, Johanna,
Okay.
go ahead.
Yeah, thank you so much for having me. It's very exciting. What you guys, the West African Stroke Initiative, what you're doing, and hopefully I know there's a lot of work to be done, but hopefully this will be helpful for patients. You have a large population. I'm sure I heard there was a recent Vein of Galen patient. So uh, I'm going to share my screen. Yep. And let's see if this works. You can see the
Yes.
first slide? Okay.
Now we can see it.
Yeah, so I'm going to talk about vein of Galen malformation, which is something that we see a fair amount at Mount Sinai, largely because of Professor Alejandro Bernstein, who is my mentor. He's now retired from clinical practice, but still around, and he's one of the founders of the field of neurovascular surgery and built this practice over several decades. But um, so these are financial disclosures related to companies that I'm working with and grants. But yeah, thank you for having me. So to start, the vein of Galen malformation, I'm just going to give a little bit of history. It's basically, and this is a nice illustration of it here. It was first mentioned, the vein of Galen related to arteriovenous malformation was mentioned in 1896 in the literature. And some of this history was reviewed and gathered by my colleague I work closely with, Dr. Tomoyoshi Shigematsu. But back in 1896, they described a frontal AVM draining through the vein of Galen on autopsy. And again in 1923, it was described on autopsy a dilated vein of Galen. The vein of Galen is the deep central vein draining the deep parts of the brain. And then in 1937, it began to realize that this was a congenital condition these aneurysms were related to shunting arteriovenous malformations. And really the disease remained highly deadly until the end of the last century. When we get to more modern times in 1989, Ray Baud, a French neuroradiologist, was the first to describe really deeply the embryology of this disease, and the first recognition of the vein of Markowski as the embryonic precursor to the vein of Galen, the median vein of the prosencephalon. And in embryology, as the fetus develops, this vein, midline vein, coalesces and is connected to the sagittal sinus and the torcula via a falcine sinus and a straight sinus. And it's thought that the vein of Galen malformation develops around 11, or begins to develop around 11 weeks in utero of and that causes arteriovenous shunting to the median vein of the prosencephalon, and keeps the falcine sinus open. And with time and discovery of more cases, it came to be realized that we really see two categories of vein of Galen malformations. Grossly, one is called the choroidal type, where there's multiple high flow fistulas and a plexiform network can form, and this drains usually anteriorly into the median vein. And then there's a mural type where there's single or a few large fistulas that drain directly into this dilated vein. And I understand the patient that some of you may have seen recently had maybe a third type, which isn't a true vein of Galen malformation, but it's a fistula that forms adjacent and then drains into the vein of Galen. But for this talk, I'm concentrating on vein of Galen malformations. But in reality, when we look at all of our patients, they're not easily categorized into these two types, and it really does seem to be a spectrum where anatomically where the shunts form and where they connect to. Prevalence, this is a rare congenital vascular malformation, less than 1% of all AVMs, 1 in 58,000 live births approximately. So yeah, in the US, maybe about, if you estimate, maybe about 60 to 70. Some people estimate a little bit higher, 80 patients per year. But it's the most common cerebral AV malformation detected prenatally, and it accounts for about 30% of all pediatric vascular malformations. So, in the US, prenatal ultrasound is very very commonly or standardly used, and that's often how it's picked up. So, compared to other diseases that we screen for in neonates, like the amino acid disorders, for instance, it's a very similar rate. Pretty rare, but it's possible to pick up. So the presentation in the neonate, they can often present with high output cardiac failure. This is due to the high flow of blood directly shunting into the vein and back down to the heart. And this sometimes necessitates treatment acutely. And this is often seen in that choroidal type of malformation. In infancy and childhood, if the patients don't get recognized early, they are missed on prenatal ultrasound, they don't present in heart failure, we can see development of hydrocephalus or macrocephaly. And these are often the mural types that present a little bit later and get picked up that way. And that can proceed to developmental delays, seizures. You can have development of venous hypertension affecting the brain and development. And sometimes we see this incidentally, very occasionally in our center, if patients get a CAT scan for some other reason that they pick up this midline dilated vascular structure, and then they're diagnosed with a vein of Galen malformation. So what does it look like in utero? So here is ultrasound looking at the head of the fetus, and this hypoechoic structure in the middle of the vein, brain is suspicious. So when this is seen, then the technician will put color onto the Doppler, and you can see that this is a high flow lesion. And then when it's discovered, we then proceed to do a fetal MRI to confirm the diagnosis. And you can see again on the fetal MRI, there's this dilated midline vascular structure. Yeah, and so the diagnosis really by imaging, clinical presentation, clinical symptoms, and then moving on to treatment. So when we discover this in utero, the patients are referred to the maternal fetal medicine, the high-risk obstetricians, and they are monitored very closely, often frequent visits with repeat ultrasounds, and we really prefer to keep the baby in utero for as long as possible, or at least close to term. So throughout the years, we've settled around 37 weeks, to schedule a delivery. The reason that we don't want to treat earlier is that the risk of doing an interventional neurovascular procedure on a preterm baby is much higher. However, this is balanced against the fact that some of the time when you diagnose this, if it's a large amount of flow, they can begin to experience fetal signs of basically brain melting. So steal of blood, and the brain does not develop normally, even in utero. So we settled at about 37 weeks. They're also followed closely by fetal cardiology with fetal echoes, and that looks for signs of heart failure, looking at the size of the vena cava, superior vena cava, and the function of the heart, and screening at both the MFM and fetal cardiology for development of hydrops. Those are all things that if we see, we may consider, the obstetricians would consider delivering the baby earlier. And importantly, we try to deliver the baby when possible at a center that can do the neonatal treatment, because they can be born in severe heart failure, necessitating emergency type of procedures. When we look at our outcomes for neonates, not just those diagnosed in utero, but those that are diagnosed within the couple days of life, looking back about 20 years ago, 2005 to 2010, we looked at 16 patients. 9 required treatment in the neonatal period, and of those, there was 1 death, and about 66% or 2/3 had normal or near normal development. So this is a fairly good outcomes after the advent of endovascular treatment, which occurred in the late 80s to 90s. We recently went back and looked at our more recent patients. So in the last 10 years or so, and this is a busy slide, but I'm just going to zoom in on the outcomes. And so we had 28 cases over about 10 years that were actually delivered at Mount Sinai. There were others that were transferred in, and they had prenatal MRIs to look at. And so of those, this is sort of the breakdown still. So if you're looking at all patients, about a little bit less than a quarter went on to palliation. So these are babies that during the development in utero, their brain developed significant injury, and it was felt that this was too, there was no hope for meaningful survival. So we recommend palliation at that point. The babies are delivered, and without intervention, they succumb. And then about a little bit more than a quarter did not have severe heart failure. So the shunt was small enough that they were born and they could go home. And then we brought them back for treatment later in infancy. Usually we bring them back at about 6 months of age. And then, so about a half of the babies they were born in significant heart failure and needed the intervention. And when that happens, there's some data, the age at first embolization is usually about day 2 of life. Sometimes it's a little later, a little earlier, and they needed about 2 embolizations during the initial hospitalization. The about 66, again, is very, very, that statistic hasn't really changed. About 2/3 of these patients survive and then meet their developmental milestones. There's some that have mild neurologic deficits, and then there's some mortality after the first embolization, about 12 to 15%, depending on the numbers. So it's still very severe diagnosis, and but it's become, this was uniformly fatal before the 1990s. And so we try to look at the kids that we diagnose in utero and try to predict, especially, obviously parents are very interested. We're very interested in how can we predict what category the baby will end up with at birth. So we looked at about 21 out of 35 neonates that were born here that had the fetal MRIs and fetal echoes that we could look at to see or anything in that data can predict whether they would need an urgent neonatal embolization or they would become too severe to receive measurable benefit. We looked at a lot of different things, like the diameter of the falcine sinus on the scan, which is something that's been reported as very predictive. And then on the echo, there's a lot of different parameters that you could look at. The VTI here is the amount of blood flow in the aortic arch, or just beyond the aortic arch, that's going up into the head instead of down to the body. And looking at the ratio between the SVC and IVC, looking at estimate of cardiac index, looking at the size of the heart, so the cardiothoracic ratio is the chest to the heart ratio, tricuspid regurg. And there's some of these do predict, basically the more severe the heart failure, as you can imagine, in utero, then the higher the risk that they would need an intervention at birth. And so, and then also the medial lateral diameter of falcine sinus does have a predictor, but there's some subtle differences in our cohort that we found in other cohorts, that even at the larger sizes of the falcine sinus, we can obtain good outcomes, but at the very high end of the curve, when the malformation becomes very big, it is a bad prognosis. This is how it's basically measured. That you see where the draining vein, the falcine sinus, is narrowest, and then measure the mediolateral diameter. And so, and this is essentially just this series of images showing, what we hope to happen when the babies are born. There's this high flow. This is a vertebral artery injection, lateral, looking laterally. The posterior, the back of the head is here. Eyes are here, and you see these multiple fistulas connecting to the vein of Galen, very dilated vein, very quick return of flow to the heart. These fistulas will be closed, and then the vein eventually thromboses. And in this case, there's not really hydrocephalus or effect on the brain. I'm just gonna skip that part. So there was some a report recently that I'm going to mention. There's a trial in Boston Children's where they're looking at actually doing this treatment in utero, where in the pregnant woman, if this is diagnosed, puncturing directly into the torcula with a needle, and then placing coils into the arterial pouch to decrease the flow and to essentially prevent injury to the brain and prevent the need for neonatal embolization. They recently reported the outcomes of the first 7 patients, and what they reported, there are 7 patients, 5 had actually underwent the embo. 2 of the procedures were aborted due to maternal instability in attempting the embo. 4 patients actually, of the 5 that underwent the embolization in utero, 4 after birth actually did need to undergo further neonatal embolization. 5 out of the 7 patients had unscheduled deliveries, so 3.2 days post-procedure on median. And I think 3 of those were preterm. So 3 survived. So 43% mortality. The 3 that survived are developmentally normal. So based on this data, I mean, this is obviously not something that could be done in most centers. It's a very high tech kind of advanced technique to be able to do fetal surgeries. We don't do it at Mount Sinai, but at this point, I think it's a promising idea. But at this point, it has not been proven to be better than what is standard of care. So the embolization, the treatment is really that's really the treatment of choice for the last several decades. Prior to the development of neurovascular techniques, there were surgical attempts at closing taking out the malformation. Those are it's obviously very high risk and bad outcomes if you look at the literature back in the 70s and 80s. The transarterial embolization with liquid embolics is the standard in most high volume centers at this time. And the technique is to close the fistulas at the site of the shunt, so close to the vein. And the goal of treatment, it kind of depends on the stage that you're in, but in the neonate, the goal is really to get the baby out of high output heart failure. So, we work very closely with the neonatologists and the pediatric cardiologists to try to determine that point where the baby can breathe on their own, eat on their own, and are able to go home. If they can't do those things, then we proceed to embolization until and try to reduce the shunt to the point that that's possible. It's a staged procedure. If you do too much at once, you can cause too abrupt closure of the shunt can lead to hemorrhage. So we really do it in stages. And then later in infancy or in childhood, the goal is also to prevent the high pressure effects on the brain. So decrease venous hypertension. We look for signs of venous hypertension, looking at calcifications in the brain. And if any of those things are happening, we continue to embolize. We're also looking to decrease the risk of hemorrhage. It's a relatively rare thing in the vein of Galen malformation to present with hemorrhage, but it's a possibility. And we at our center like to, our ultimate goal is cure, to completely close the malformation and get rid of the shunting. Sometimes that's possible, sometimes not possible, but the goal is to reduce the flow as much as possible to the point of cure most of the time. And so this part I'm going to go over for, I think there's some neurosurgeons and interventionalists. This may be a little bit more detail into the anatomy, but the shunt is located in the choroidal fissure. That's where the vein of Galen sits. And the feeding arteries are often from the choroidal system. So you can see anterior choroidal, most of the time posterior choroidal, medial and lateral posterior choroidals off the PCAs. Sometimes you can get involvement from the limbic system. In fact, most of the time. So we see pericallosal arteries coming into this area off of the anterior cerebral artery and off of the distal posterior cerebral arteries. And sometimes we get perforators, so transmesencephalic thalamic perforators coming up to the malformation. And this is just some angiograms showing these various types of arteries, the medial posterior choroidal, lateral posterior choroidal, pericallosal would be in the midline, and then these transmesencephalic feeders, which are often trickier because they're running through midbrain and thalamus, and so we prefer to not touch these when possible. Here's a good example of the anterior choroidal and pericallosal coming in to the shunt. And sometimes, in cases, in a little bit rarer cases, we can see leptomeningeal collaterals or involvement of the middle cerebral artery branches and coming in. That's often in high flow shunts. And sometimes in very severe cases, we see, or later on in the patient's treatment course, we see meningeal branches coming in, superior cerebellar, posterior meningeal. And this has some implications for the techniques for treating. The typical thing that we like to do is to use glue. So we identify, in this case, a large choroidal fistula. This patient is luckier because they don't have a lot of perforator feeders. And in that case, you can advance a microcatheter. So this is a detachable tip microcatheter because what we're using is a type of glue, NBCA. It's a cyanoacrylate that is like crazy glue and has the potential to glue the catheter in place. So we navigate that to the side of the shunt. So here you can see with injection of contrast, there's a large fistula. It enters the vein somewhere around here. On the AP view, on the lateral view, it's entering the vein around here. And this is the deposition of glue. It's some of the glue has already come out. It's actually entered into the vein. But the goal is really to seal the entrance and make sure this fistula and the entrance right here is sealed. And so that's the injection of glue. In this case, with a detachable tip catheter, you can have the glue come back and sit on the catheter because when you're ready, you can detach the tip at this point and leave it in the patient. And so the patients go through a series of these treatments where multiple large fistulas are closed, and they come back every 3 months or so until hopefully we can achieve cure. Or it's in this case, sometimes you get to a point where you have no clear access to the malformation. In this case, the patient is lucky, and the flow going through here is so small that the entire thing thromboses. If you try to do too much in the beginning and close the entire malformation and thrombose the entire vein of Galen as shown here, then you can have back thrombus that forms, in this case, in the straight sinus and then into the torcula, and that can be devastating. That's why we do it in a staged fashion so that the vein shrinks. There's been different techniques. Actually, in the very beginning in 1986, the first reported treatments were to put coils inside the inside that bubble via direct exposure over the torcula. But that, if you look at the reports, the outcomes, they may close the fistula, but the outcomes aren't that great, bleeding, and bad development. Then with the transarterially placing coils, that was the next thing that was described. But again, the outcomes weren't great. And so in the 1990s, that's when Bernstein, Lashunius in Paris and Terberge in Toronto pioneered doing the liquid embolic to seal the fistulas. Recently, we've introduced the transvenous as a last stage where for cure of the malformation using a pressure cooker technique, which is basically meaning you're putting filling the vein, but putting the liquid backwards into the malformation. And then as I just showed in Boston, they're doing transtorcular coiling in the fetus, but it's where the outcomes are not so great so far. The teamwork is key. As I mentioned, we work with the pediatric neurosurgeons, sometimes very occasionally, hopefully, we may need their assistance to manage hydrocephalus with endovascular or endo ETVs, the third ventriculostomies, and then sometimes rarely shunt. We prefer not to shunt these patients. Because if they're developing venous hypertension and hydrocephalus, the treatment really is to decrease the venous hypertension by embolization. The pediatric neurologists follow the patients, the neonatologists, pediatric intensivists. We have, when we do the procedures, our pediatric anesthesiologists are very, very involved. And then before the MFM and pediatric cardiologists, sometimes recently, we've been having some of the patients, and I'll talk a little bit at the end about the genetics and potential for medical treatments. And so we've been working with our hemo colleagues and geneticists to see if we can find mutations that are causing these types of malformations and that have targeted medical therapies for this. And so just to show some details about a neonatal procedure, we preserve the umbilical access in a neonate when we need to go in. So when the babies are born, we have the neonatologist put in umbilical artery catheters, umbilical vein catheters they use. And this is because if you go through the femoral arteries in the neonate, those can thrombose, and then because you need multiple stage procedures, this becomes a big problem in the future. And in these kids, they're very small, often under 4 kilos or so. So you very quickly can get to your contrast dosage limits, and you have to be mindful of the fluids. And then, as I said, we use the NBCA, and while we're injecting, we use hypertension or pacing that I'll mention. This is an example of an umbilical artery catheter that we've removed over a wire and then exchanged for a 4 French sheath. And then through that 4 French sheath, we can put a longer catheter that goes up and then into the cervical vasculature. And here's an example again of this type of glue injection. We get to the side of the fistula, and a little bit escaped into the vein, which is okay, but you want to close the actual fistula site. The priority is for normal development. This is a a recent case, which is a 5-week-old who presented with seizures. And so again, a little bit of a delayed diagnosis. And you can see the reason was because of venous hypertension. You see a lot of dilated arterioles and venules in the brain. And here's the MRA showing the malformation. This baby actually, while they were at an outside facility and while waiting, suddenly went into status, and then 11 days later came back in status to that same hospital, and this was the change. So this is a little bit of a dramatic situation because it doesn't often happen that something changes so drastically. And this is likely because they developed a venous outflow stenosis. So in the cases here where you look, sometimes the vein here, the left sigmoid jugular junction, has thrombosed. And so while this is protective to the heart, so the heart is not receiving this high flow, the baby's not in heart failure, the brain is, suffering immensely. The high flow shunting is backing up into the brain tissue. And so this is all, and also an indication for emergent type of treatment. You can see that the flow is going out the cavernous sinus and down the other jugular. And so this patient we brought for embolization, transferred over to our hospital, and this is a navigation of the catheter, the detachable tip catheter. In this case, we actually have an intermediate catheter in place to help us navigate. And then we see the connection again, a choroidal vessel into the vein. And the injection of contrast shows the fistula. There's some technical considerations of how close you can get to the side of the vein. You want to be in the fistula to inject the glue. And here's the glue cast showing sealing of that fistula. There's another injection where some of the glue is now entered into the vein, and another injection. So there's multiple fistulas in this case. I believe we closed 3, and that was in the placement of the glue here. And the before picture you saw, and then the after picture, those fistulas are no longer connecting. You can now see better the brain parenchyma. There is a lot of stagnation of contrast now in the vein, and the venous phase shows that the blood is still kind of stagnant to get out of the brain, but it's improving. And this is the before and after picture. And so again, you do have to do it in stages, but in a case like this, we may do it a little bit more frequently to get the pressure off the brain. This is something that we've done recently. So you can imagine the catheters in a high flow situation, you're injecting glue. You want the glue to stay. One of the risks is that the glue can go through the malformation, end up in the lungs. And so we've been using this technique recently where we have our pediatric interventional cardiologists help us, and they put a pacing wire into the ventricle. And using that, we can do something that's called rapid ventricular pacing, where you basically increase the heart rate. You pace the ventricle to, here it's going at 170, 160 actually. The heart rate, sometimes we usually go over 200. Here you go, 280 or so. And in that situation, the blood pressure plummets, and then you can do this for about 30 seconds. So far, we've been able to do it safely. We haven't had any cardiac arrest or situation. And you can see that the glue, instead of flying away, it sits in place, sealing the fistula. So it's something that we've done about 9 kids or so with this. And we think it's a good technique to get the glue to seal the fistula. The problem is that it is easier to seal the fistulas much more proximally, and this is a case of a patient who was treated elsewhere where coils and maybe onyx were placed very proximal to the vein. And so closing, you want to close at the side of the fistula. I think this is an important thing. If you close far back with coils, you can end up blocking the path to the malformation, to the actual shunting point. So this kind of patient comes back, 6 months later, and instead of the vein shrinking, what they've done is all of those small collaterals to the malformation have become bigger, but these are much more difficult to navigate a catheter through, and it makes the treatment riskier going forward. So, it is a technique. If you coil proximally, you can get the babies out of heart failure, but then your future treatments are problematic. So a couple other techniques that you can that we've developed is using balloon catheters, and this is something that that's pretty common now for neurovascular technique. We have catheters that are balloons that you can also inject through, and those, in that case, I'm just gonna skip to show that this is in the situation where we get this fine network, and that sometimes we have this development of these really fine vessel networks that are very small. You can't navigate through. The only thing you can do to close these is to spread a liquid embolic through them, and the best liquid embolic for that is onyx, or this is what we have available in the U.S. There's other agents like Phil and Squid that are available outside the U.S. But this is a type of liquid embolic that slowly polymerizes, so it's not going to harden right away like crazy glue. You have time to push it through before it solidifies. And we've shown, and this is one of our areas of research right now, is why do patients develop this? I think it has to do with individual patient biology. Most of the time, it can have to do with technique, like closing the fistula more proximally can probably make this more prominent. But when you see this develop, it's not good. We publish it's not good for the patients. They require more treatments. They develop more symptoms, hydrocephalus, neurodeficits, when these small vessels develop. And so it's a good patient population for using a new technique. We've had using the mini scepter with onyx penetrating through the choroidal vessels. Obviously trying to stay away from the normal brain, but penetrating the onyx just through the pathologic vessels. And so we've done this now. This is a publication from a few years ago. So we've done this more times now. Sometimes you can have intraventricular hemorrhage. There's complications, but it's been a very successful technique in general. This patient, for instance, had coils develop this fine vascular network that we're calling, and then there's a balloon catheter, and you can sort of see that the balloon is inflated. This is the mini scepter is about 2 millimeter catheter, and you can see that the glue or the onyx is penetrating through that network and then reaching the vein. And again, here you can see penetration through the network to the vein. And so, I'm going to show one case to illustrate the techniques. This is a 12-month-old boy who had a vein of Galen malformation diagnosed, actually workup for headaches and macrocephaly, which was because of hydrocephalus. And he had a developmental delay, both motor and language, otherwise playful and interactive. His echo showed subtle signs of increased shunting and cardiac return. So dilated chambers, but didn't demonstrate any congenital heart disease. The function of the heart was good. And so the kid was scheduled for embolization. This is what we saw on the MRA. There were these, he had already developed this fine vessel network, which seemed to be in the choroid fissure, but also seemed to be in the brain itself. The vessels feeding the malformation were traveling through the thalamus. This is the angiogram. It's the same one that I showed before, showing that this kind of extensive network. And so he came in for treatments. We did a few transarterial glue injections and reduced some of these vessels here. And then in one treatment, we decided to do a basically mini scepter with onyx. So this is the kind of cast that you can get. This is a sort of aggressive cast because we put a lot of onyx into this part of the malformation. And it's really important to try to note that you're staying in the choroidal fissure. It's very hard to know that. But we're monitoring the onyx coming through the posterior the pericallosal feeder, and then going through that network. And then sometimes it will, it seems to have found, for instance, here, one of the perforators, and it's coming back into the arterial feeders. So you have to be careful to not reflux too much into those feeders and cause thalamic stroke. And here is the end of that treatment. So we've reduced, even with that amount of embolic material, we've reduced the malformation, but the malformation is still open. And you could see going back, the vein a little bit smaller, and then 3 months later, a little bit smaller. He came back for more transarterial treatment, and then 2 months later, he came back for more treatment. You could see that this is what was remaining. We were able to close some of the big fistulas coming that way, and then he came back 2 months later. And then finally, at this point, everything is very small. So this is the kind of case where you could say, stop here and follow the patient. In his case, we felt that it was safe because what we could see remaining were just these perforators and just this little bit of malformation left. And so we did the transvenous technique called pressure cooker. Dr. René Chapeau in Germany published that in 2014. This technique for AVMs, you can use it, in this case for vein of Galen, where you put coils in the vein. So you come transjugular backwards through the vein, put a catheter again to deliver the liquid embolic beyond the vein in as close to the nidus as possible, then coil off the vein so that the onyx goes retrograde. And so it becomes a little complicated, tricky. You may need multiple people involved. Usually we do this with 2 attendings. And then you can inject the onyx backwards and seal off that last bit of the fistula. And at that point, the vein you're committed, you're closing the vein, so you have to close the nidus as well. If they've developed this network, we feel that you should try to close the network and not just coil off the vein. This is at the end of that procedure, completely gone. And then he came back a year later. We often do a delayed imaging or angiogram because these kids can develop delayed other things like dural fistulas. And so he came back, and this is a durable closure of the malformation. I'm not going to talk too much about this because I think we don't have too much time. Yeah, we're almost at the end, but we're doing some studies here to look at what's causing the vein of Galen malformation. And there's lots of mutations that you could see in the pathway related to vascular endothelial growth factor that is involved in cancer biology, for instance. And some of these kids, you can find mutations of the genes that they've been reported in the literature. And we know that this article from the New England Journal from 2018 showed that a lot of adult brain AVMs have a mutation in this KRAS protein. So we're looking to see if we can find mutations in these kids. We have an IRB approved study where we're drawing blood from the periphery and also from in the lesion when we get close to it with the microcatheter. We're looking at genomics, which we haven't sequenced. We're currently sequencing, and we're also looking at transcriptomics, so looking at the RNA sequencing and what is being expressed at the different sites. And so what we can see so far is that the brain is expressing different proteins and genes that you would think are related to the brain. So it's making sense compared to blood that we draw from the femoral artery. And we can see that those are related to known genes in the literature associated with vein of Galen and AVM. So the interesting thing about this is that some of these mutations actually have medications developed for them because of their involvement in cancer. And so we're hoping to learn a lot about the biology of why some of the kids develop this angiogenesis. If we can understand the biology, maybe we can target those gene expressions with medicines and prevent that from happening. I'm going to quickly just show, we had a patient that's not a vein of Galen in which we were able to sample the blood and found a mutation in a gene called PIK3CA that's often it's mutated in breast cancer. Sometimes it's related to vascular growth, and that gene that protein has a medication that's targeted that they use in cancer. This is just some pictures of, he was a very interesting case because he had this orbital malformation, orbital lymphatic malformation, and he had genetic testing from his periphery that was all negative. And then when we drew the blood from his dural fistula, we collected it from the superior petrosal sinus here. We actually found a PIK3CA mutation. And so this mutation, this gene has a target, a medication that can be used, alpelisib. I'm just gonna say that we started this, and then all of his malformations started improving, and he's actually coming back soon for another angiogram. And his symptoms have been very stable now for a couple of years. So, at this point, I think vein of Galen is rare. There's, I tried to go through management and treatment, and then in the future, hopefully we can look at the genetics of these patients and be able to target them with medicines instead of these complicated treatments, or perhaps use the medicines to make our endovascular treatments simpler in the future. So I'm going to stop and just take questions, because I think we're at the time for questions. So thank you very much.
Yes, thank you very much, Professor Fifi, for this fantastic presentation. And we're now going to go to questions and answer session. Over to you, Dr. Izepe.
Thank you very much, Professor Ismail. Thank you, Professor Fifi, for that wonderful presentation. We thank you, Professor Ismail, and the rest of the team in Nigeria for all your hard work on these grand rounds. We're really excited about the future as we work together with all other stakeholders to facilitate world-class comprehensive endovascular neurointerventional services and stroke care in Nigeria and across West Africa. For this, more information is forthcoming in the future sessions about opportunities for anyone who is interested in engaging in this much needed work. The first question here on the chat says, I think it was asked early on during the presentation, is safe delivery by C-section or spontaneous vaginal delivery? Which one is the safe delivery for the patients?
Yeah, we leave it up to the obstetrician, actually. Yeah, it's I would say probably more than half do C-section, but it is safe to have a vaginal delivery. Yeah, and it's typically scheduled, so they'll schedule an induction of delivery.
Okay. And also, one of the other questions here, I'll read them first before I ask mine. Thank you very much for the lecture, Professor Fifi. This is by Onya Chiazo. Since the question is, since the best approach is to do the embolization in stages, is there any criteria or guide on which vessels to select for embolization at each stage? Or is the choice left to the discretion of the neurointerventionalist, depending on angio findings before each stage?
Yeah, it's at the discretion of the interventionalist. Usually if they're in heart failure, respiratory distress, we aim to close the biggest fistula to decrease the largest amount of flow. Once they're out of that period, say later on, we're still trying to close the big fistulas first, essentially. But we base it on the angiogram at the beginning, or the MRI if we get an MRI beforehand.
One of the questions here is asking about training. The question goes, thanks a million, Prof, for this enlightening and expository presentation. This is great. How can you be of help to train interested young faculties in your reputable citadel of learning? The question goes, I have no doubt Nigeria is willing to build up such capacities.
Yeah, I think it's this sort of didactic training as well as hands-on training. I know that you are, or there are people traveling to train the interventionalists in Nigeria now by scheduling cases, and then several people coming to do hands-on training as well. I think it's a little for stroke, which is obviously, this is sort of a niche kind of diagnosis, but for stroke it's and aneurysms, things like that. It's probably easier for people to travel and then train, and then have some people travel out of the country, but maybe to areas close by to do some say 6 months or a year fellowship. But I think those are a combination of all those things is going to be necessary.
Yeah, during our own training, there was no specific training for just treatment of vein of Galen malformation. It's
Very
incorporated
rare. Yeah,
it's incorporated in the overall endovascular training, which is
right,
2 years.
right.
And if
This
you're
is very
lucky,
rare.
yeah, if you're lucky to train under someone who has experience, then you get trained as well.
Yeah. Yeah, oftentimes though, I get calls from people around the country or sometimes outside the country, send pictures, give advice, because it's very rare. So if a Vein of Galen case pops up or a neonatal case pops up, it's there are many of us that see it. There are a few of us that see it often, and we're always happy to help.
Yeah. Next question here is talking about it's popping up so fast, it's moving away from me. It
Yeah.
says concerning arterial injection, I think.
The routes of transarterial.
Concerning the procedure, what are the routes for administration of the transarterial injection?
Yeah.
And what are the leading complications?
Yeah, so complications, it's like any endovascular procedure, the route, besides in kids, it's usually transfemoral. So femoral artery up into carotid or vertebral, and then up into PCA, ACA to the malformation. And then inject from there. The complications, like very similar to any endovascular disease, is stroke or hemorrhage. And those I guess the different I talked about is if you embolize too much, then you can thrombose and then cause sinus thrombosis or torcular thrombosis. So those are the complications.
The next question here is talking about neonates being fragile, and the NICU
Yeah.
is limited to a few centers of excellence here in Nigeria. Is there any multinational body interested in helping in that perspective, even if a PPP arrangement? This is a technical question. PPP, I don't know what PPP stands for.
That is a private
Public
partnership.
partnership.
Oh, okay.
Yes, but I think it's the WASI that is doing that. So the West African Stroke Initiative is trying to do that.
And
Yeah.
then, the next question here is actually touches on what I was going to discuss as well. We were taught in fellowship to avoid shunting as much as possible, because this is mostly the hydrocephalus is mostly due to hydrovenous framing,
Yeah.
not the typical hydrocephalus we treat with VP shunts.
Right.
How do you address this if you have, especially for general neurosurgeons who may be interested in VP shunting?
Yeah, if it's in specifically for vein of Galen malformation, obviously for other diseases, if you have a hemorrhage and you have impaired outflow, you may need to put a shunt or a drain. If it's the fact that you're getting slow hydrocephalus because of venous hypertension, we really try to avoid it. We really try to decrease the shunting, so closing off the big fistulas. However, sometimes the vein actually presses on the cerebral aqueduct, and so sometimes we get into a situation where we're saying, well, maybe it's not because of venous hypertension, maybe it's a direct obstructive hydrocephalus. And so very rarely we'll put it, but it's very rare actually that we do that. More often now they're doing the endoscopic third ventriculostomy, the ETV. And then if that doesn't work, go for shunt. We have one patient now we're considering shunt, but I can't remember. It's been several years since we put in a shunt on a patient.
Yeah. Would you try doing maybe doing an EVD first and seeing, buying some time so you could.
If it's a hemorrhage, yeah.
Yeah.
If it's a hemorrhage, yeah. And then we do EVD, then we do ETV. And then, if it's for instance, a complication from a procedure where the kid has an intraventricular hemorrhage,
Yeah.
the VP shunt doesn't really, if it's the hydrocephalus from the malformation, the VP shunt doesn't really solve the problem. It takes away a component of the pressure, but the shunting is still there. And then oftentimes, once you're treating maybe a high pressure is measured, but once you're treating, then they develop subdurals because the pressure is relieved. So it ends up being, a cycle of problems.
Yeah, question from Prof himself. He's asking in your own experience, which vessel feeders arise, which vessel does the feeders arrive the most?
Usually it's posterior choroidal, like off the PCA.
Yeah.
Yeah, posterior cerebral artery branches.
Yeah. And then vein of Galen are in grades with proportionate mortalities. Your presentation has raised hopes that the future is bright for children born with vein of Galen malformation. Is there any type of grade to avoid for embolization based on mortality figures and your experience?
Yeah, I think I meant like if the brain is irreversibly damaged, which it depends, I guess, on the social situation, probably other resources in the country, like you said, lower middle income countries, because if there's significant brain damage, even if the kid survives, they're gonna need like lots of support. So there's a grade, right? Like if both hemispheres are completely out, we don't offer treatment. If say there's a focal PCA territory stroke, or quarter of the MCA territory is encephalomalacia, we still offer treatment, but I think it's a judgment call talking to the parents, because if you say this kid's not going to be normal, they're going to require some support, they will die if we do nothing, and then we make a decision with the parents what they want to do.
Yeah, I remember early on in fellowship, we were taught about the bicentre. I think it's
The
bicentre.
bicentric, yeah, that's for neonates, and we don't use it. We had a recent meeting with the Vein of Galen specifically, and we don't use it anymore, like in how it was made. It was a scale to judge heart failure in the neonates and to select some patients as futile, don't treat. Some patients as wait for later, but it's not. We sort of use subtle judgments, because in that scale, if you had any brain abnormality, they wouldn't treat. It's sort of a judgment nowadays.
Now, one of the things I also have is the pressure cooker technique. What I've learned is that you actually use it as adjunctive. Have you ever tried using transvenous pressure cooker as the first go-to treatment?
No, I think that's in the history of the treatment, they first were using this at that point the vein is too big, usually like in the beginning, before you can decrease the flow, the vein is very big. So if you were to coil the whole big vein and fill it, I think you would get thrombosis of the torcula, and it would be not good. So we wait till the vein's small.
Right. Let me check the chat again. Someone here is asking about, thank you, Prof. Any links for scholarships on vascular training, 3 or 6 months fellowship? I don't know if you will be able to answer that.
I don't really know. Yeah, I mean, it's in the US, it's so regulated to do official training. You have to go through a lot of steps. I mean, that we don't have like a 3 or 6 months felt like hands-on kind of fellowship. We have it's like a 12 or 24 months full training.
And then
I think other countries may, like closer, like I don't know if Egypt or
it will be
Turkey.
difficult. Yeah, it will be difficult to find a specific training for that short length
Yeah.
of time that is well structured
Yeah.
outside of externships.
Yeah, it's 1 year or
Mhm.
right. 1 year or 12 or 24 months is standard.
The next one here says, thank you for a wonderful presentation. Transvenous embolization looks groundbreaking treatment for vein of Galen malformation. When do you judge you can safely TVE treatment,
Yeah.
transvenous embolization? Okay, yeah, I think you've
Yeah,
answered the
I
question.
think we answered when the vein is very small,
Yeah.
it doesn't have, because you're closing off a vein that isn't used, it doesn't really have a risk of venous congestion. We really judge to see if we see internal cerebral veins coming into the vein of Galen, then we don't close it off. So yeah, you want to make sure that it's not being used by the normal brain as well.
Okay, I think we would we've 17 minutes past the hour. I think you have other things to do now. Thank you very much, Prof. Fifi, for this presentation. We have a YouTube recording of this for those who may want to go back and review it. Professor Nasir, I don't know if you have any additional comments to make before we close.
Yeah, really, thank you very much. This is a wonderful presentation. And we look forward to seeing you the subsequent presentation. And please, I would like to inform all the participants that our next grand round will take place on Wednesday, October 14th, 2026. Please keep an eye out for the flyer, and we look forward to seeing you there. We will share the flyer by email and on our social media channels and the website. Feel free to invite colleagues if you have any idea for topics you would like to be presented in the future grand rounds. Please reach out to Dr. George. Today's recording, as well as the previous recording or previous grand round, will be uploaded to the West African Stroke Initiative YouTube channel. You can see it on the channel box. Thank you for joining us. We hope this session has been valuable for you. Have a wonderful rest today. Thank you, Professor Fifi.
Thank you.
Thank you.